So this discussion is going to focus on conditions and some of the anatomy and physiology involving the cardiovascular and hematological systems. So if we look at an overview here of what we're going to be looking at, so we're going to be, again, start with just general function of the system, get into a little bit of the generic pathological processes and some of the signs and symptoms, and of course, given what we're looking at here, we're going to look at how exercise and more intense activity is going to affect the system. We'll talk briefly about cardiovascular screening and kind of mention how we could kind of screen individuals during pre-participation exams for issues. Again, talk about the examination, particular to cardiovascular pathology and some of the risk factors, then get into the conditions, which again, we'll be going through the conditions, fairly quickly, because again, I'm just going to kind of give some background on them. And then, as a part of the class, you'll do what you've been doing with the conditions, going and getting the signs and symptoms and some of the management. And again, looking at this as far as athletic training relevance, I mean, cardiovascular disease is actually the leading cause of exercise-related deaths. And most of the on-field sudden deaths are related to cardiovascular issues. So we want to be looking at here as far as, what are some things we need to be on the lookout for and what could happen so we could kind of mitigate this. Getting back to some risk factors, again, if you think about risk factors, again, high cholesterol, diabetes, high blood pressure, a lot of things are hereditary with cardiovascular. So that would be some stuff that would come up in even like a pre-participation screening or as part of your assessment in an individual who might be having an issue with the cardiovascular system. All right, so here we look at the heart and we kind of look at the kind of general anatomy of the heart. So if you're looking here, you have the four chambers. So you have the right atrium, right ventricle, left ventricle, as the blood gets pumped through, and we'll talk more about how kind of the blood circulates and what the heart. So basically, the right side of the heart is going to pump blood, pump deoxygenated blood back to the lungs. The left side of the heart is going to pump the oxygenated blood and send it to the rest of the body. You have other soft tissue structures, obviously, that make up the heart. You have the myocardium, which is essentially the cardiac muscle. So cardiac muscle is a specialized type of muscle. As again, we know the heart beats and kind of helps to basically cause contraction of the heart to cause the blood to circulate through the different chambers. You have the endocardium, which lines the inner portion of the heart. Okay, so that the chambers inside the heart are lined with endocardium. I don't have it on the slide. I realize this after the fact, but there's something called an epicardium, which basically surrounds the entire heart. So it's basically a tissue that just kind of surrounds the entire heart. And then you have the pericardium, which is tissue that attaches essentially the epicardium to the thorax. So it basically kind of holds it in place, okay? And all of those tissues are prone to infection, okay? So there could be infection that could take place and you could get edema that forms in between the tissues. So that's, kind of anatomically relevant to what we're looking at with those different areas. When we look at the blood vessels, so blood vessels basically have three different layers. And those different layers have different thicknesses based upon what type of blood vessel you're talking about. So again, arteries, veins, capillaries circulate blood throughout the heart. The walls of artery and veins have three layers. So they have an inner layer, which is basically made of endothelium. That's the tunica intima. They have a middle layer, the tunica media, which is elastic fibers and smooth muscle, and then an outer layer called the tunica adventitia of connective tissue. Again, those layers, as you see when you look at this picture here, are a little different. Obviously, your arteries have a much thicker muscular layer than the veins do, and again, arteries kind of pump themselves, whereas veins kind of work more through the contraction of the muscles around them. You can see here that capillary walls are very thin. Now, in this picture, they're showing a lymphatic vessel, which is just made up of epithelial tissue. but capillaries are very thin also compared to the arteries and veins as well, and because with capillaries, they're responsible for where that exchange of oxygen and nutrients take place. So when we're looking, for instance, down here, you can see, so here's the oxygen-rich blood coming from the artery. At the capillary, that's where nutrients and oxygen kind of escape, and then you see the carbon dioxide and waste products will be taken back through the system. So again, capillary walls are going to be very thin and only contain some tunica interna where that exchange can actually take place. As also just in addition, looking at the lymphatic vessels, again, remember you have the lymph nodes, which we talked about briefly in the immunology chapter. Lymph nodes are basically small expansions that act as filters. So they kind of drain, the lymphatic system in general is responsible for draining, filtering body fluids. It also absorbs fat and has immune function. And it should be known that all lymphatic or all lymph must travel through at least one lymph node before entering the bloodstream to kind of act as that filter. And that's kind of something that runs in conjunction with the arteries and veins as we kind of go throughout the circulatory system. And again, the fluid through the lymphatic system moves the same way as it would through the venous flow, where in reality you need muscle contraction to help kind of assist with the flow of the fluid. So when we look at the heart, okay, the heart itself requires a blood supply, and that blood supply is going to be supplied to the heart via the coronary arteries. And we'll talk about, coronary artery disease and what that means as far as the heart is concerned. The heart actually has its own conduction system. So if you look here at the heart, so up here on top of the right atrium, you have what's called the sinoatrial node. And then in between the right atrium and right ventricle, you have the atrioventricular node. So essentially what happens is you get an electrical signal that goes from the SA node to the AV node, and then there's various nerve fibers that go kind of throughout the heart. So again, the heart has its own electrical conduction system that we could actually measure the activity with what's called an electrocardiogram, which we'll talk about the different parts of that and kind of what a normal electrocardiogram looks like. But they actually cause the atria and ventricles to contract, and it's a coordinated contraction because blood has to essentially get pumped. It has to go from the right atrium to the right ventricle, and then the right ventricle, it's got to come out of the pulmonary arteries, and then when you're talking over here, it's got to go from the left atrium to the left ventricle, and then out the aorta and through the rest of the body. So that's got to be a controlled contraction. So with the SA node, when the SA node fires, the atria contract. When the AV node, the ventricles contract. That also gets us into the concept of systole and diastole. So systole is when the coordinated contraction of the atria and ventricles contract. Diastole refers to when the periods where they are both relaxed. So, and that's where when you get into blood pressure, that's when the pressure is going to be, obviously, that's usually the higher number for systole, where the system's actively contracting, and then diastole is when it's at rest. And we'll kind of talk about what normal blood pressure is. It's changed a little bit since the textbook's been published, so we'll talk about that. And we also look at the idea of heart rate, so how many beats per minute, and discuss what gets classified as bradycardia and what gets described as tachycardia. So continuing looking at the heart, just some values to kind of keep in mind. So stroke volume is the amount of blood that gets pumped into the aorta with each beat. Okay, so with each time the heart contracts and basically kind of ejects blood out of there, that's what's known as your stroke volume. Okay, so as blood is kind of moving throughout the heart, so for instance, when you get atrial contraction, the blood is going to move through, there's two valves, okay? On the right side of the heart, between the right atrium and right ventricle, you have what's called the tricuspid valve. On the left side, you have what's called either the bicuspid valve or the mitral valve. That helps to prevent the backflow of blood coming through. So basically, once the atria contract and the blood gets pushed through to the ventricles, that valve keeps it from coming back. So that's important to know. So when the atria contract, the blood gets moved through those valves. When the ventricles contract, those two valves will close off to prevent backflow of blood, and then the blood will go again from the left side out to the aorta, and on the right side to the pulmonary arteries. So one thing you'll notice is that anatomically, the left ventricle is bigger than the right. And if you think about why that would be, it's because the left ventricle has to pump blood to the entire rest of the body. So, and that's again what we measure stroke volume from. That's the amount of blood that enters the aorta with each beat. And then from there, you could measure what's called your cardiac output, which is essentially the volume of blood pumped per minute, and all that would be your stroke volume, so how much blood's coming out, and you would multiply by that by your heart rate, and that would tell you what your stroke volume is. So when we're looking at blood, we talk about blood pressure. So blood pressure is the pressure of the blood exerted against the arterial walls. So the idea behind having blood pressure is because, again, for oxygen and nutrients to get through from the circulation, you have to have pressure against the wall. So that maintains that perfusion. So that's why maintenance of blood pressure is critical. But so if it falls too low, for instance, you could suffer like brain damage from lack of oxygen. However, if it gets too high, you can also cause a lot of issues where you damage the capillaries and cause a lot of arterial damage. So it's important to know that. So again, that's going to maintain blood flow and perfusion to the head, the organs, the muscles. So that's important to kind of keep in mind. Now, if we look at what affects blood pressure, again, as we know, we talk about systole and diastole. So systole is going to be that pressure as the heart is actually contracting. Diastole is going to be when it's at rest. So you're going to have those two different measures, and we'll get into, what would be considered normal blood pressure and what would be considered, too high and too low. So you have your red blood cells or your erythrocytes, which are responsible for carrying oxygen. Red blood cell production is going to be regulated by what's called erythropoietin, which is a hormone in the kidneys. You have your white blood cells or your lymphocytes, which we talked about extensively, that are involved in the immune response and involved in soft tissue healing. And you have your platelets or your thrombocytes, which are responsible for blood clotting. So, and again, table 6.1 will kind of, summarize the function of them, but pretty much what we said is pretty much what they do. The erythrocytes will transport oxygen, remove carbon dioxide. The white blood cells are going to be responsible for mediating the immune response. And we talked about phagocytosis, and then the thrombocytes are going to be responsible for clotting. They also give the normal levels. I'm not going to make you memorize normal, blood values for those. Certainly if you ever had an individual who had to get blood work done, usually they kind of put those with the values that the patients have anyway, so you don't necessarily have to commit those to memory for our purposes, but they, you at least can kind of give you an idea as to what you need to be looking at, because that's a common thing for a lot of pathologies, is to get a blood cell count just to see if there's any issues with the circulating blood cells. So the response to exercise, so again, if you just think about what happens to your heart rate. So again, we know that when we go to exercise, our muscles are going to demand more oxygen. So that increased demand for oxygen is going to cause the heart rate to have to increase. So the heart rate and respiration rate will both significantly increase when exercise begins, which is going to produce stress on the heart, okay? Left ventricular mass and volume does increase as a result of regular aerobic exercise. That type of adaptation is normal. So, we'll talk about, kind of abnormal cardiac hypertrophy and what that means, but that's a normal response. So when you get an increase in ventricular mass and volume due to aerobic exercise, that's going to be a normal response, and that's okay, because that's going to make your heart work more efficiently. Now, there are some slightly different adaptations in aerobic exercise versus resistance exercise. So aerobic will basically cause, again, that increase in ventricular mass and volume because of the resistance that occurs with resistance exercise. So because of the fact that you have a much different stress on the cardiovascular system when you're exercising, but since, you know, oxygen demand doesn't necessarily increase, you tend to get more an increase in the actual muscle mass of the left ventricle, not so much a increase in the volume, okay? So the heart muscle will thicken, not so much though, you won't get as much of an increase in the volume that you get with aerobic exercise. So that's a slight difference. Again, both of those adaptations have benefits to them. We're going to talk about some of the pathological issues as it relates to hypertrophy of the cardiac tissue as well. So pre-participation screening, so the 36th Bethesda conference basically set up minimal components for a pre-participation exam. So if you look at table 6.3, they talk about those minimal components. So the minimal components are a family history, a personal history, and a physical exam. And those, you know, again, so the family medical history and personal medical history, if you take a look at that table, it talks about what some of the issues that you want to screen them for. So just kind of make note of them. And then the physical examination, which the physical examination for the most part is something you would do for a lot of cardiovascular stuff anyway. They talk about, again, getting resting heart rate, getting blood pressure, auscultation of the heart in supine and standing. You could assess the femoral pulses and also observe for signs of Marfan syndrome. Those would be all things that you would include in a pre-participation screening. So you would have your questionnaires to talk about, you know, things again like family medical history, any previous, you know, signs and symptoms. Have you experienced dizziness, lightheadedness with exercise? So that's what you would kind of include within that. So within that whole thing, again, anytime you're screening for high school and college athletes for this, those would be included within that. And then we talk about diagnostic tests. So, you know, some of the diagnostic tests associated with cardiac pathologies, again, these don't always get included. There is a suggestion. So we talk about the minimal components being with the physical examination, but there's other things that could be included. Electrocardiogram is always good, an echocardiogram. So with an electrocardiogram, you're measuring just the activity of the heart, you're measuring the actual electrical activity. An echocardiogram involves actually looking at the heart and looking at the size of the chambers and everything. It's something common that you will do with somebody who maybe you're screening for Marfan syndrome. There's cardiac MRI and there's exercise stress testing, which can all give you some information on some of the things that could be going on with a patient with possible cardiovascular issues. So your electrocardiogram or your ECG and your echocardiogram. So here, this is what I was talking about with the electrocardiogram. So this is a diagnostic tool that looks at the electrical activity of the heart. And what you're seeing here is what a normal electrocardiogram would look like. So you have the P wave, what's called the QRS complex, and then you have the T wave, and then there's all these segments in here. What we're just going to talk about for now is understand what the different waves mean. So the P wave is basically atrial depolarization, which is when the atria contract. The QRS complex is ventricular depolarization, and that also kind of covers atrial repolarization as well. And then the T wave is ventricular repolarization. So when a cardiologist, for instance, is going to look at an electrocardiogram, this is kind of what they're looking to see. They're looking to see it essentially look like this. Any type of change, or if any of the waves become inverted, say, or these segments increase, because the segments are also important because of the timing of the heart contraction. Over here you have what's called an echocardiogram. So this is a little different. What this will actually do is look at it uses ultrasound technology to basically image the heart. So this could kind of tell you, for instance, if you have like an abnormal thickening of a ventricular wall, like with something like hypertrophic cardiomyopathy, which we'll talk about. It can also look at other structural deformities if someone has valve disorders or something of that nature. That can also kind of tell you what could be going on with that. This is an actual picture here. So, the radiologist can look at this and determine, if there's any type of abnormalities with valves, or if the tissue, if there's any type of abnormal hypertrophy of the tissue. So your general signs and symptoms as we're looking at this. So, chest pain, again, here's another one of the algorithms. So again, always, take some time to look at these algorithms for kind of your clinical decision-making purposes. Again, chest pain, particularly in the left side of the chest, or anything that, radiates into the neck, shoulder, arm, and the pressure particularly worsens with exertion. That would be something to note. Dyspnea, where you have shortness of breath. So dyspnea will occur typically when cardiac output decreases. So that's going to cause someone to become short of breath. And again, many cardiac problems you end up seeing a connection with the respiratory system. So that's going to be important to note. Dyspnea tends to improve with rest, which reduces oxygen demand and worsens with activity. So that's when, if a patient's telling you they're feeling short of breath, if they have pure dyspnea, that could be because of, again, you could be looking at an issue where there's some type of circulatory issue where if the blood flow is decreasing to the heart, there's going to be less oxygen available to the body. Cardiac issues related, when you're looking at breathing issues, typically cardiac stuff is going to be a lot of times too unaffected by posture, unlike pulmonary causes. So pulmonary causes will sometimes be affected more by posture, more so than cardiac issues. Fatigue, again, fatigue will be an issue with the cardiovascular system, because if you think about it, there's going to be a decrease in cell metabolism, because that's going to be affecting the perfusion of oxygen and nutrients and things of that nature. So someone will experience fatigue. And then you have palpitations. So, a patient might come to you and say that it feels like their heart's fluttering, or they have skipped beats, and that could be caused by an arrhythmia. So again, that would be something that you would want to get examined or get further evaluation by a physician. But again, the more information you can give in your referral, that will also kind of help with that diagnostic process. So for syncope, or essentially a loss of consciousness, so syncope is a loss of consciousness and postural tone, usually caused by a sudden reduction in blood supply to the brain. So there's usually going to be three causes of syncope. Either you get peripheral vasodilation, where basically the blood vessels in the periphery all kind of abnormally vasodilate, increased intracranial pressure from bleeding inside the brain could cause syncope, and then any type of acute reduction in cardiac output. So these are a lot of times essentially your three primary causes of syncope. And again, the reason why someone's going to pass out is going to be because of reduced blood flow, which is going to cause reduced oxygen to the brain, and basically the brain activity is going to decrease very quickly and cause that loss of consciousness and motor control. So if you have an unexplained syncope, because that could be caused by a serious heart problem, that's going to be something that typically requires immediate medical care. So if you don't have a cause for it, don't know why, or it's the first time it's happened, that would be something you would want to get looked at right away. Claudication is another thing. This is basically what you look at with claudication is when blood flow to the lower limbs gets blocked, you get basically this cramping and aching sensation in the limb. So, this many times is going to happen in the lower limbs in individuals who have circulatory issues. You could also examine the skin. You can look at the nails, you can look at the skin temperature, feel the skin temperature, the color, and the just general appearance. So, so look at the skin, look at skin lesions. You can also get what they call clubbing and spooning of the nails. There's pictures of that in your book, and again, some of that could just come about regarding again showing issues with blood flow and tissue ischemia that would cause some of those abnormal development of the fingernails. You want to check the skin because vasomotor disorders can cause the skin to become cold and clammy from vasoconstriction, or on the flip side of that, hot from vasodilation. So vasodilation will usually make the skin, red, feel more warm. Vasoconstriction is going to make it feel cool and clammy. Okay. Also, when you look at the skin and nails, you could, if there's lack of oxygen, you could look at it being very pale. Or in the case of with vasodilation, again, hypertension, it could take on more of like a bright red color. When you're looking at that, again, blue or purple. Skin or nails also shows lack of oxygen to the affected tissue. Paresthesia could be something that can occur as well. So again, nerves need good blood flow because they need oxygen in order to function. So paresthesia could also be a sign and symptom not only of just a nerve problem. It is a nerve that's causing it, but if there's lack of blood flow, that's going to cause that. And then edema tells you that there's some type of swelling. Again, usually the type of edema you're going to experience if it's not from an acute injury, if it's related to the cardiovascular system, it could happen for a couple of different reasons. You could have obstruction of a lymph vessel or vein. Cardiac failure in general will cause generalized edema throughout the body. Probably not something you're going to see in a lot of younger, healthier individuals, but again, could be a sign of something. Anytime there's usually a vascular issue, particularly if you're talking an obstruction, the edema is going to be distal to the site of obstruction. Okay, so when we look at pain patterns, again, anytime you're talking pain from the cardiac system, and in particular the heart, you're usually going to be experiencing a crushing type of pain. Like when you're talking like myocardial infarction, for instance, person suffering a heart attack, that's going to be a crushing type pain. Like people will explain, like it almost feels like, that they talk about like it feels like an elephant sitting on their chest. And usually we're going to feel that where it comes from a spinal level C3 through T4. And again, you're going to feel that in the neck and the throat. The medial side of the left arm will get some referred pain to. Vascular pain is typically described as like a tearing, sharp, or throbbing pain. Many times there's going to be muscle cramping that's associated with this and fatigue. Again, the nerves could experience paresthesia with this anytime there's some sort of vascular related issue. So that's some of the different sensations and stuff like that individuals would experience as far as their pain patterns from the cardiovascular system. So the history and the physical exam, again, look at the family medical history. Again, that's going to tell you a lot as far as this. A sudden cardiac death under the age of 40 is a really strong risk factor for cardiovascular disease. Or even just, a cardiac incident, I would go as far as to say under 40 is significant. If there's a family history of, hypertension, or if the person has hypertension, diabetes, things of that nature, that would contribute to that. High blood lipids, if a person has Marfan syndrome, smoking obviously is an issue. Again, hopefully, again, with your active population, you're not dealing with a lot of people who smoke. And obviously, with active population, you typically wouldn't have this, but inactivity is obviously a problem as well. Again, you look at your symptoms, which we kind of already talked about and discussed. Again, from an inspection standpoint, you have your Marfan syndrome, and we'll talk about some of the things you can look at with Marfan syndrome that could kind of tell you. And again, there's just risk there for the weakening in the connective tissue that occurs with that. And again, you can do some basics as far as looking at heart rate, and we'll talk about what normal respiration rate, heart rate, and everything should be when we're going through the exam. So for the history and the exam, so again, you want to note respiration rate, because again, that's going to, again, the respiratory system and the cardiovascular system are going to work kind of hand in hand with each other. So respiration rate for adults is normally about 10 to 15 breaths per minute. Infants could be somewhere between 30 and 60 breaths per minute. Young children, 20 to 40, older children 15 to 25. So those are your ranges. And again, you also want to note the quality of the respiration. So again, you want to note the rate, rhythm, depth, the effort, because that all kind of tells you about what that individual could be experiencing. As far as blood pressure is concerned, we want to look at what would be considered the new blood pressure guidelines. So blood pressure guidelines have kind of changed. Your normal blood pressure should be less than 120/80. Basically, once you're at a systolic of 120 to 129 over a diastolic still of less than 80, typically they consider that elevated blood pressure. Stage 1 hypertension is classified as 130 to 139 systolic, 80 to 89 diastolic, and then stage 2 hypertension, you're greater than or equal to 140 systolic over greater than or equal to 90 diastolic. And when you're looking at systolic and diastolic, so again, those numbers, so those are the guidelines. I mean, for instance, you might have like a slightly, maybe more elevated diastolic and things like that. Where it gets to be a concern is when you look at the diastolic. So a high diastolic is slightly more concerning than even an elevated systolic, because the diastolic is when the cardiovascular system's at rest. So if that tends to get elevated, even more so, you do get concerned about it, because again, you have stress on the system when it's essentially should be resting. Okay, so a heart auscultation is when you're using a stethoscope to essentially listen to the heart sounds. And what you're basically going to be doing is typically performing it over 4 distinct listening zones to check the different valves to make sure that they're working appropriately. So here we have, so you'll be listening for the lub-dub noises. Now first I'll talk about the actual locations, and then we'll talk about the actual noises. So the aortic listening zone, which you can see right up here, that's located just to the right of the sternum in the second intercostal space. Then you have the pulmonic, which you can see here. That's the pulmonary listening zone. That's in the second left intercostal space. Then going down the left sternal border, you see the tricuspid valve, located, in the left, fourth, or fifth intercostal space, basic general area, and then the mitral listening zone, which corresponds to the apex of the heart. It's located in the left, fifth intercostal space, basically at mid-clavicle. So if you go right from mid-clavicle down into that fifth space, that's the mitral. And essentially what you're listening for is you're listening for what we call the lub-dub noises. So you're listening for what's called the S1 and S2, and then you're listening for any type of murmurs as you're listening to it. So the lub-dub, the lub is associated with the mitral and tricuspid valves closing. The dub is associated with the aortic and pulmonary valves closing. Again, there's also an S3 and an S4. Now the bell of the stethoscope tends to be a little more sensitive to them because they're high pitched. So those sounds, they're abnormal or extra sounds. So S1 and S2 are your normal, and that's what you're listening for. So the S3 and S4 are like extra sounds. Okay, so basically what you're listening for is any type of extra sounds or any type of muffled or abnormal sounds that could be caused by the valve deformities. And again, some of the sounds are going to be produced by the turbulence of blood flowing through the heart. So essentially, if you were to hear anything other than the S1 and S2, that would be cause for referral. Other pathological things you'd be listening for, I had talked about murmurs already. Bruits, which are kind of like rush, harsh pounding sounds, would be something that would also you'd hear. That would be something that you would hear. Actually, as you go to there's other major vessels you could listen to, particularly the abdominal aorta. So like that would be something that would be a concern more like in the abdominal aorta would be that that bruit, which you would hear, and that would be kind of an abnormal vascular sound as a result of auscultation. Okay, so looking at the exam, we already talked about respiration rate and blood pressure. We'll talk quickly about heart rate. So normal heart rate should be between 60 and 100 beats per minute. Greater than 100 beats per minute is tachycardia. Less than 60 is going to be bradycardia. Obviously, tachycardia is normal while a person is exercising. Their heart rate's going to get elevated. And you can actually have a bradycardia at rest that isn't pathologic. It actually shows increased efficiency of the heart, particularly when you have somebody who's very well conditioned. So their resting heart rate will tend to be a little bit lower. So very well conditioned people could have a resting heart rate as low as like 40 or 45. And what that just tells you is that their heart is essentially pumping out more blood with each beat, so it doesn't have to beat as often. So it's actually a sign of good conditioning, if you will, and a very efficient heart. So now we're going to get into our conditions. So sudden cardiac death, and usually any type of sudden cardiac death, and again, there's various pathologies that would cause this, but we're going to talk about it in and of itself because, again, we talk about how this is a very common cause of a lot of sudden death, if you will, on the field. It's usually going to occur within 1 hour of the onset of exercise or shortly after ending. The causes of this are various types of disorders that we're actually going to talk about. So, hypertrophic cardiomyopathy, congenital coronary artery abnormalities, okay, the electrical and conduction issues are some of the things that can cause this Comorciocortis, which we'll discuss. Those are all things, a lot of what we're talking about are possible causes of this. Contributing factors involve high intensity exercise, electrolyte imbalances, high body temperature. Any sudden cessation of physical activity can possibly cause sudden cardiac death, particularly when it's matched with one of those individual causes. Okay, so hypertrophic cardiomyopathy, and there's different types of cardiac hypertrophy that could occur, and we had talked about at the beginning some of the adaptations that occur as far as exercise. So now this is an abnormal development of the cardiac muscle. So what happens in the case of hypertrophic cardiomyopathy, or what you just consider pathologic hypertrophy of the cardiac muscle, you inherit abnormal cardiac fibers, and what that does is it causes ventricular obstruction and could cause an arrhythmia. So if you look here, so again, here's your normal heart. You can see so it's a cross section, so you can see the atria and the ventricles. Here you see the abnormal hypertrophy. So when we were talking at the beginning of the chapter about hypertrophy of the cardiac muscle, what would be considered normal hypertrophy as a result of exercise, what would happen is this would thicken, but the inside would maintain its size. You see here, I mean, if you look, the ventricles look almost non-existent, and that's what you end up getting with a pathologic enlargement of the heart. This is the leading cause of death in young athletes. So we had talked about the sudden on-field death, particularly with athletes. So this would be something that, ideally, if you could screen for you, what you do. And again, just in your reading, kind of note the at-risk individuals for this condition. Coronary artery anomalies. So what this looks at is abnormal positioning of the coronary artery. And just a note here quick is that the most common is an abnormal positioning of the left main coronary artery. So again, in your readings and kind of in your notes for your signs and symptoms, you can look at some of the different types. But essentially what happens here is the left main coronary artery, again, remember the coronary arteries are responsible for supplying blood to the heart, because just like everything else, the heart needs blood as well, to maintain oxygen perfusion and everything for the cardiac muscle. And in the case of a coronary artery anomaly where the coronary artery is kind of in a different position, what that's essentially going to do is basically possibly impinge on it. There's an illustration in your book showing this. If you look at you can see where the normal coronary artery is and what happens when it's not positioned appropriately, and they show it in conjunction with the pulmonary artery and they show compression of that and the issue that would cause as far as blood flow to the heart. Okay, heart failure, and you're not going to see a lot of heart failure in, again, what would be a more common patient population in sports medicine. But again, we still have to kind of understand the pathology. Heart failure in general is just an insufficient heart pump mechanism. So again, we know what the heart's responsible for. It's gonna pump blood throughout the body. It's important to note that when that pump mechanism becomes inefficient, there's various things that could happen in the body. And if you look, there's different types based on the location of the heart failure and if it's acute versus chronic, okay? So you can have acute left, acute right, and chronic right, and they all basically produce different signs and symptoms based upon the mechanism. So in other words, you have situations where you'll get pulmonary edema, you'll get situations where you'll get more peripheral edema from heart failure. And if you think about when you go and look at this table, you make the connection between why you would have pulmonary edema versus systemic edema based upon whether or not you have left and right heart failure. So take a look at that and see if you can get an understanding of that. And if you're not sure, just ask questions about it. Cor pulmonale is a particular type of heart failure where you have right-sided heart failure as a consequence of a pulmonary disease. So there's some other type of pulmonary issue that actually perpetuates the heart failure. Myocardial ischemia. So this is when there's a lack of oxygen being delivered to the blood. So basically the blood supply to the heart is essentially compromised. So anything that would limit that would cause myocardial ischemia, and one of the the most common things that people experience with this is as angina, or that pain in the chest because of it being ischemic, and again can be caused by many different issues. Okay, so coronary artery disease is probably the one we think of the most with this, but certainly there's other issues where the coronary arteries can be impacted and that blood supply can be compromised. Arrhythmogenic right ventricular dysplasia. So this is a fatty infiltration and fibrosis of the myocardium. So there's two different pictures here. One is just kind of a graphic picture. Over here, where you can kind of see the fatty infiltration. Here's an actual heart that has had that fatty infiltration, and in particular, you end up having more issues with the right ventricle. Causes and consequences of this. So there's a genetic component to this, and the biggest thing is either a ventricular tachycardia or ventricular arrhythmia that can become life-threatening. And again, what a person who has this will begin to experience is they'll just start to have your common cardiac signs and symptoms with activity. So again, we had mentioned that if you have these cardiac signs and symptoms and you refer the individual to a physician, again, they'll kind of have to find the cause, because again, obviously a lot of the conditions have very similar signs and symptoms, but this would be something that would be possibly included in your differential diagnosis there. Valve disorders, again, another sort of set of disorders that we have. Again, these can be either congenital deformities or acquired conditions. So we have the mitral or the bicuspid valve on the left, and we have the tricuspid valve on the right. And again, this is usually going to be due to some sort of structural issue within the heart. You could also have, again, various presentations of this. There could be stenosis around the valves. There could be some type of structural malformations. Again, the most common thing you'll kind of note with this, with auscultation, is a murmur present. And again, that's just going to be due to the abnormal flow of blood through the actual heart itself. And probably the most common type of valve disorder is what's called the mitral valve prolapse. So again, essentially with a mitral valve prolapse, again, there's an illustration of this in the book, but again, if you go to that left side of the heart, the mitral valve, or what we call the bicuspid valve on the left side. So when the atria contracts, we know that the blood flow goes through to the ventricle. When the ventricle contracts, the mitral valve has to close up, so there's no backflow of blood back into the atria. And in the case of a mitral valve prolapse, the valve kind of flaps backwards a little bit, and that allows that blood to flow through. And again, when you listen to heart sounds, if it's significant enough, that's where you'll hear the murmur or that abnormal sound when you're listening to the heart. Paroxysmal supraventricular tachycardia. So now we're getting into some conduction disorders. So if you're kind of looking through a lot of these conditions, and again, in particular this chapter, there's a lot of different conditions to talk about. You can kind of categorize them essentially by what they are. So, I mean, as you're kind of going through, you have disorders of the myocardium and coronary artery disease. Those are things like the heart failure, the myocardial ischemia. You have different types of, again, the enlargement of the heart. Here we're actually just talking about different types of conduction disorders. So if you go back to what we talked about, that electrical conduction system in the heart with the SA node, the AV node, and the other fibers that kind of run through the heart that regulate the heartbeat itself. So this is a conduction order that causes rapid heart rate at rest. Okay, so obviously we know at rest, our heart rate should be lower. Obviously, the more well-conditioned an individual is, that actually creates a situation where their heart rate, they will have what's called the resting bradycardia. And this is going to happen due to a defect in the discharge of the SA node, atria, and AV node. So there's a defect in that connection between the SA node, the sinoatrial node, and the atrioventricular node. And what this could do is actually cause like a very rapid resting heart rate that'll occur intermittently. So we're at, you're seeing like usually a heart rate at around 150 beats per minute at rest, okay, which is obviously very high. And then that would tell you that, again, this would be something that you would want to look into. So if, you have a patient who says, well, I notice at rest my heart seems to start beating really fast, again, that could be part of that conduction disorder that you'd want to look into. Long QT syndrome, again, another conduction disorder. And what we're looking at here is an extended QT interval. So remember I said at the beginning of this, we had talked about the electrocardiogram and kind of what it should look like. And here I have a picture of an abnormal and a normal electrocardiogram. So the QT interval is the time it takes for the ventricles to depolarize and repolarize. So, again, the QRS complex is ventricular depolarization in general, and that QT interval is the time it takes for it to depolarize and repolarize, because the T wave is where it repolarizes. Now, the issue with that is longer times interfere with the heart's contraction ability. So again, it throws off the timing of the heartbeat. So with the supraventricular, the paroxysmal supraventricular tachycardia, we're primarily just looking at a really rapid heartbeat at rest. With this, what an individual will occur is they'll get a ventricular tachycardia, but it's due more to that prolonged time between the depolarization and repolarization of the ventricles. Wolff-Parkinson-White syndrome. So what actually is happening here is there's an accessory conduction pathway. So and what that's going to do is that accessory conduction pathway is going to cause one ventricle to actually depolarize before the other. So if you look at this picture here, here's your normal electrical pathway. Okay, so starting at the SA node, and you can see the pathway kind of going through the heart. Well, here you get a little accessory pathway, which will cause the ventricle. So this ventricle will depolarize before this one does. And again, that's going to cause, that could cause various types of abnormalities within your heartbeat. It could cause an atrial fibrillation or even a ventricular fibrillation. And essentially what a fibrillation is kind of like an abnormal quivering of that part of the heart. So again, if you just look at the heart beating, it has this very well-timed, pumping of the heart, whereas a fibrillation is when you just get this kind of dysfunctional quivering, if you will, of whatever part of the heart is having the fibrillation. Okay, so some other different things, so kind of moving off of the cardiac conduction syndrome, is you have Marfan syndrome. We mentioned Marfan syndrome briefly before. This is something that you'd want to screen for. It's actually a connective tissue disorder, so it's not inherently just a cardiovascular disorder, because there's other issues that come about when people have Marfan syndrome. So it's a connective tissue order in general. So however, the reason why it's talked about here with the cardiac system is because a good portion of individuals with Marfan syndrome develop deformities in the aorta. Okay, so the connective tissue in the aorta basically ends up weakening, and they end up having problems and possible sudden death due to that. So again, what you want to look for here, and again, I'm just going to briefly mention some things because I want you to kind of bring together those signs and symptoms on your own. But here you see what happens. You get abnormal dilation of the aorta, and that could cause some issues with circulation. It can actually cause the aorta to rupture as well. But these are some of the things you would see in individuals: the pectus excavatum, or that kind of where their sternum kind of caves in a little bit. The arachnodactyly with the long fingers. And again, there's a lot of other signs and symptoms that you would see. Typically, the people have a tall, thin body type. Their arm spans longer than their height. So if you measure their arm span and compare that to their height, you would see that. They tend to have disproportionately long legs. Thoracic spine kyphosis. Again, the sternum deformity as we have here. There's hyperlaxity in the joints. Okay, so their joints tend to be go through large ranges of motion. They could kind of bend them in different ways. Overlap of the thumb and fifth digit when they kind of wrap it around their wrist. So if someone can take their thumb and their fifth digit, wrap it around their wrist, and there's an overlap, that would be something where, again, those would be various signs. So when you have somebody and they kind of have this, that general kind of build, it may be something you would want to screen for, just to make sure that an individual doesn't have an undiagnosed Marfan syndrome. Comorciocortis is a blow to the chest during cardiac repolarization. So essentially what happens with Comorciocortis is that an individual would take a very focal blow to the chest. You see here in the picture, they're showing the example of a batter in baseball. And what happens is, during the cardiac repolarization, it has to happen right at that point. However, it is always a possibility. And what essentially happens is you get a ventricular arrhythmia because of that. So it kind of throws off, again, that electrical conduction. And ideally here, you get an AED on the person within about 2 minutes to basically save their life. That's probably the most important thing at that point, is to get that AED out and get it on them to reestablish the normal heart rhythm. So again, with hypertension, and I gave you at the beginning of this the new standards and guidelines as it relates to hypertension. So those are the more recent ones that we looked at. So again, hypertension in general was once considered resting blood pressure over one, and that's still basically your stage 2 hypertension. So your stage 2 hypertension is still considered greater than 140 over greater than 90. I think, but again, what happened is they kind of redefined the elevated and the stage 1 hypertension, which I talked to you about earlier. So again, optimal BP is ideally less than 120 over less than 80. Again, pre-hypertension, they don't really talk about pre-hypertension anymore. Again, it's more just what we consider elevated blood pressure and stage 1 hypertension. And, again, the treatment has kind of changed slightly as well based upon these new standards. And then again, the stages of hypertension. So we had mentioned those earlier. So again, you'll have stage 1 and stage 2, and that'll kind of tell you as far as, again, what your treatments would be. Primary versus secondary hypertension. So this is something that we can talk about here. So primary hypertension is when someone has hypertension, but there's no known cause. Whereas secondary hypertension is when we know that there's something else that's causing the hypertension. So we also call primary hypertension essential hypertension. Again, unknown pathology, but again, we kind of know that there's other things that contribute to it. Whereas secondary hypertension is a result of another actual medical condition. So many times, whether it be a renal disorder, so a disorder of the kidneys, a hormonal disorder, or some type of metabolic disorder, that will be considered then your secondary hypertension. And again, long-term consequences. So there's a lot of long-term consequences to hypertension. Again, obviously, the ones we commonly think about: heart disease, stroke, different types of peripheral vascular disease. But there's other things as well: retinal damage. Okay, so the small arteries in your eye will be very sensitive to that. Renal failure, again, the small blood vessels in your kidney, because if you think about it, basically your blood vessels are under more stress because of the pressure against the arterial walls. So that can cause some damage to those vessels, and even a hypertrophied left ventricle that can cause some issues as far as the cardiac system is concerned. Okay, anemia. So now we're going to look at this. This is a blood disorder. So what we're looking at here are lower levels of hemoglobin, or your red blood cells. Again, primary risk factors when you're looking at anemia typically involve malnutrition and chronic disease. So malnutrition and chronic disease will usually be your kind of your primary things you see with anemia. Some other factors you can see, intense physical training can actually damage red blood cells. Prolonged use of analgesics, heavy menstruation in females, and different types of medical treatments can actually cause anemia. There's actually also something called dilutional or sports anemia. So this isn't a true anemia. It's not uncommon among individuals who are very physically active. And the reason being is that exercise actually increases blood plasma volume, but it doesn't affect red blood cell production. So in people that do this, their blood tests may show anemia because when they look at the red blood cell count, it looks low relative to the volume. So again, that's where we call dilutional or sports anemia, because basically, because of the plasma volume being so high, essentially the blood is diluted, if you will, which almost makes it look like the red blood cell count is lower, but in reality, it's actually not. The amount of red blood cells is normal. You just have a greater plasma volume. So for that, there's not really anything that would need to be corrected in that point. Sickle cell disease and sickle cell trait, again, we're still talking blood disorders here. So this is a situation where you have abnormally shaped red blood cells. In order to have actual sickle cell disease, you have to have two genes for it. So it's a recessive genetic disorder. So you have to have both genes. You have to have it from both your mother and father. If you only have one, you can have what's called sickle cell trait. So what happens in sickle cell trait is that essentially the blood cells aren't sickled all the time, but through exertion you can actually get sickling to occur. So again, the same issues that you would have with full diagnosis of sickle cell disease, you could end up having a lot of the same complications for that. This is more common in African Americans, so in particular it's good to screen again for sickle cell trait, because that would be something that could kind of get passed by and people could not realize they have it until an issue occurs. The biggest risk factor for sickle cell is what's called acute exertional rhabdomyolysis. And the issue here, for someone who will have exertional sickling, someone with just sickle cell disease will likely not be participating in athletics. But sickle cell trait, they could, okay, because again, it's just they might just experience exertional sickling, And what happens with exertional rhabdomyolysis, it's actually a catabolic destruction of the muscle tissue. And the issue with that is the myoglobin, which is a muscle protein, and the different enzymes that kind of come out because of the damaged muscle, it enters into the bloodstream and kind of overwhelms the kidneys. So the kidneys are going to be responsible for filtering the blood, and what that could do is end up causing acute renal failure and shock, and then even possibly death. So because what you're going to basically do is you're going to be blocking the filtration process of the kidneys, because it's going to be overwhelmed with those byproducts of the muscle breaking down. Hemophilia is a blood disorder that impairs clotting ability. So, this individual, so we know that, for instance, when you have a wound or even a soft tissue injury, part of the healing process of that is to form a clot. In this case, the clotting ability is impaired. Now, it should be noted that there's various types based on the clotting factor missing. I'm not going to make you responsible for knowing every single characteristic of every single type of hemophilia, because there's quite a few of them. But again, just in general, know your signs and symptoms and how you would treat, for the most part, the general forms of hemophilia. Okay, so we're going to talk about trauma and occlusion syndromes together, and we're going to speak specifically to one particular type of occlusion syndrome. Trauma, anytime you have repeated blunt trauma, so basically like repeat contusions to an area, if you're playing a sport where maybe there's very focal impacts to a particular region, you could start to get some distal ischemia to the area, where you start to get some more significant sensory issues and things like that within a body part region. Again, for the most part, the treatment for that is pretty simple. Occlusion syndromes themselves are going to be caused by just pure mechanical pressure, inflammation, or even blood clots can cause this. And there's common occlusion areas in the body that you'd have, like the subclavian artery, the axillary arteries, popliteal arteries, and the femoral arteries are some of the more common sites that you'd have this. And again, for a variety of reasons. And one of the things we look at with an occlusion syndrome is you have what are called the 5 Ps. So pain, pallor, paresthesia, pulselessness, paresthesia, paralysis are your 5 Ps. So if you kind of get a combination of those, you know that you're starting to have some type of occlusion syndrome, and then from there you'd kind of look to figure out, you'd kind of already know where the occlusion could be coming from based upon the body part area, but then obviously you have to figure out why the occlusion would be occurring. So thoracic outlet syndrome, and this is something that you would have learned about even in your orthopedic exam. So this is where the subclavian or axillary artery gets entrapped. So this is a particular type of occlusion syndrome. Again, where athletic trainers see this most commonly is in individuals who do repetitive work and have postural problems. So because of the repetitive work, muscle contraction, and the posture issues that occur, you end up getting entrapment of that artery, and again, you'll get those symptoms of vascular occlusion that you commonly see. There's other types of occlusion problems that could occur, so we'll note these. So Berger's disease is one, and compartment syndrome. So Berger's disease, or thrombogenitis obliterans, is a condition that's usually associated with tobacco use. So in that, you get an inflammation and occlusion of the arterioles, and it results in occlusion symptoms in both the upper and lower extremities. So again, with active individuals, you likely wouldn't see something like that as much, because again, it is associated with tobacco use. Compartment syndrome is something that you could see, and compartment syndrome can be acute or chronic. So, in different parts of the body, for instance, the most common area to see this is in the lower leg. In the lower leg, there's compartments. So, you have an anterior compartment, you have a posterior, you have a deep and posterior superficial, or deep and superficial posterior compartment. And basically what it is that the various muscles in the lower leg are wrapped by fascia in these compartments. And sometimes what could happen is for various reasons, and again, it could happen due to an acute trauma where, you know, there's a trauma to the lower leg and the swelling and everything builds up in the compartment and you end up getting, you know, significant vascular and neurologic symptoms, or it could become chronic in individuals who just have maybe like a thickened soft tissue in that area. Again, you would start to notice, again, the 5 Ps come into play, and again, you would basically treat the compartment syndrome based upon whether it's acute or chronic. Acute compartment syndrome is an emergency situation where they'd have to get to an emergency room to have it get treated. Chronic compartment syndrome, you typically try to treat with conservative rehabilitation. Sometimes they do surgery for it, where they'll go in and release the fascia. You know, the results for that tend to be mixed, but it can be a difficult thing to treat. You just have to find, you know, different things that could be, you know, kind of exacerbating the compartment syndrome. Deep vein thrombosis and pulmonary embolism. So this, you know, very commonly a DVT will happen many times due to after a surgery, and in particular when you have an immobilization. So it's kind of you see the little graphic that I have on the bottom. We'll talk about the significance when you have all 3 of those things together and what that's called. But basically, when cells get together and clot, we call that a thrombus. In conjunction with venous swelling, we call it a thrombophlebitis. So a thrombosis is going to be when the thrombus is present in the vein. That's what we call that. And then a thrombus that breaks free and moves from its origin and moves through the circulation, we then call that an embolus. Okay, so if you hear of a pulmonary embolism, that's when the thrombus actually breaks free, moves, and then goes into the lung. So what we look at here is something called Virchow's triad. So basically Virchow's triad is hypercoagulability, stasis, and vessel injury. So it's a combination of the blood chemistry, as you're seeing here, which causes the blood to be hypercoagulable. The stasis, meaning that the blood flow is slowed down, and then vessel injury. And those 3 things together really put people at high risk for some type of clotting issue that, you know, could then potentially become an issue. So an individual, for instance, could get possibly get a deep vein thrombosis from a significant trauma, say, to the lower leg. Okay, so that would be something you'd want to look out for. And again, the key with a lot of this is to limit immobilization as much as you can. If somebody has a surgery and they can't, you know, even going as far as people who are on bed rest, they need to make sure that this is something that's watch out for. And there's things that usually get put in place, like if someone does have to be on bed rest or there's prolonged immobilization, they'll try to take precautions and do things to limit the chances of this happening. And again, one of the bigger complications of this is the pulmonary embolism. So that's when the embolus that's moving through the circulation travels into the lung. Aneurysm is a weakness in the wall of a blood vessel. So this is when a blood vessel basically has the weakening in it, and you get this kind of like ballooning out of the blood vessel, and then that just makes it susceptible to rupture. So again, there's certain arteries that do tend to be subjected to this, and there could be significant repercussions to that. There's also something called a false aneurysm, and this occurs many times after a trauma in sports or physical activity. So what happens is, in a false aneurysm, the wall of the blood vessel will tear a little bit because of the trauma, and it could cause a hematoma formation and then some fibrous scar. Now, the important to note here is the interior diameter of the actual vessel is unchanged, so blood flow is not affected, okay? Usually what's going to happen is the person will have symptoms or issue because of it, because of the fact that it may compress a nearby tissue, but there's not going to be any real ramifications as far as the circulation is concerned. So with a false aneurysm, it could cause some discomfort and issues associated with it, but for the most part, There's not a whole lot you have to do. Occasionally, they have to be surgically removed if they're if they're very symptomatic, but there's no circulatory ramifications to it. Okay, headaches. So various types of headaches that can occur and again, the vascular system would be involved with it. There's migraine headaches. Again, there's various causes for migraine headaches, whether it's serotonin issues. There's inflammatory effects in the trigeminal nerve complex. Hormone fluctuations could cause that. There's cluster headaches that can be caused by psycho-emotional stress, alcohol, tobacco use. And again, here you're looking at maybe neurovascular, hormonal, autonomic nervous system problems. And, so when you're noting your signs and symptoms of these, note where typically the pain occurs and to differentiate between, what we'd look at. Because, migraine headaches and cluster headaches, they tend to present, their pain pattern tends to be much different between the two. Okay, toxic vascular headache. This is probably something just a lot of people might experience in general. This is, due to an infection. So again, when people tend to get, various types of like viral illnesses, one of the common complaints is a headache, and that would be considered a toxic vascular headache. Caffeine abuse withdrawal, alcohol abuse withdrawal, hypoxia, hypoglycemia, metabolic disorder. So probably one of the more common classifications of headaches would be the toxic vascular. Some pediatric issues just to note. Pediatric chest pain. So in young kids, if they complain of chest pain, more commonly it's due to a musculoskeletal issue. So, you want to look, examine their thoracic spine because, issues in the thoracic spine can kind of refer pain in and around the side of the ribs into the chest. So it's usually not a cardiac issue. Again, you'd want to pay attention to if there is any significant family history. So you would still want to ask that in your questioning. But, if there's no significant family history, they might not necessarily have symptoms, necessarily associated with exercise that would, bring up any red flags to cardiovascular issues. Then you could get into your assessment, maybe looking at the thoracic spine and see if there's any issues there that could be causing the chest pain. Again, what you do want to be aware of, particularly with kids, are various types of congenital heart conditions. So whether it's septal wall defects, vascular anomalies, again, that may need to be detected early. It's important to note that a lot of these don't necessarily interfere with sport participation. So again, there might be other treatments that allow them to maintain their physical activity. But again, you just need to be aware of more serious conditions. And we talked about some of those. So again, gather your information. If there are any significant signs of cardiac conditions, particularly in very young individuals, it would always be a good idea to refer, have them get tested and make sure that you rule everything out. And these are your outcomes. So again, pay note to the treatments and stuff and such. I did mention for some of the items, some of the significant signs and symptoms, or maybe even some things that aren't in the textbook, but make note of those signs and symptoms and your treatments as far as your kind of completion for your studying and preparation for your exam.